Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. So, I hope my audio is clear. Kindly comment if there's any issue. Okay. So, guys, today we are going to study a very important topic. I'm sorry, everything just fell. Wait. So, we're going to study a very important topic that is of the operative vaginal delivery, that which is the instrumental delivery. Okay. So it's definitely very important, and each and everything has to be done from the guideline in this case. I really don't know how to pause the live, so if there's any issue, I will not be able to pause it. So just give me a second. Actually, I don't have a tripod. I have adjusted the phone on books, so it'll just take 1 or 2 minutes, and then I'll realize and I'll understand the settings after that because my phone just keeps falling. Okay. Okay. So, guys, this is the last page of the guideline. This is the safety criteria for the operative vaginal birth. Okay. First of all, I want you guys to understand this, and after that, we'll move towards the reading of guidelines. So, it's more of a read with me session, and I will be explaining. Okay. So, first of all, decision making for assisted vaginal birth. What is the safety criteria? You should know about the whole safety criteria, that how much the head of the baby should be palpable and the membrane should be ruptured, the cervix should be fully dilated, and there should be no element of CPD and all of those things. So you have to select the optimal place of birth. What is the, first of all, let's go towards the safety criteria. So what is the safety criteria? If anyone can recall any points, please try to recall and then I'll just explain. Okay, nobody? Okay. So as I was saying that the reason why we use operative vaginal delivery is basically, I'm just going towards the page of safety criteria. I mean, just listen to me. Is that you need to shorten the second stage of labor, right? And what are we trying to do? That if there's the maternal effort is inadequate, or if we feel that the we need to shorten the second stage, or there's a lot of fetal distress, then in that case we have to apply the instrument. Okay, so let's just here. So we have to classify them. So the classification is, we have the outlet, we have the low, and we have the mid cavity forceps, right? These are the three ones. So the thing about this is that outlet, let's start with the mid cavity forceps. So the mid cavity forceps are going to be applied at the station of 0 and +1. So you just have to remember that it's going to be above +2. Okay, so above +2, once it reaches the station of +2, it becomes low. Okay, so here this table is very important, okay, both for your MRCOG and your IMM, that the fetal head should be less than 1/5 palpable. Okay, not more than that. Okay, so it should be 1/5 or less than 1/5 palpable, and the leading point should be at 0 or +1, and mid cavity can either be rotational or non-rotational. Okay, and the rotational one is Keeland, and the non-rotational one is Neville Barnes. Okay, and then we also have Simpson's, and we have Fugerson. Okay, then the low cavity is from +2 and +3, and the fetal skull is still not on the perineum, but it's on +2 and +3. Okay, so in this scenario we have again rotation and non-rotation. Okay, and the forceps are Wrigley's and Simpson's. So Simpson's is also in mid cavity, Simpson's is also in low cavity. Now the outlet is +4 +5, just before or just before the crowning. So in case of outlet, since the station is so low, the fetal head is already, you can see the scalp without separating the labia. Okay, and the skull has reached the perineum, and the rotation in this case, it has already rotated. If it had not been rotated, it wouldn't have descent. Okay, So the rotation does not exceed 45 degrees in this scenario. Okay, so it's really simple. You should just know the names of the forceps according to the station. So let's start with mid, then low, then outlet. Okay, rotational is Keeland, non-rotational is Neville Barnes, Simpsons, and Ferguson, and low is Wrigley's and Simpsons, and outlet is Wrigley's. Okay, very simple, no issue in this. Okay, so the thing is that when is it indicated, and when is it contraindicated? What are the recommendations and the contraindications? So there is no absolute indication, and you need your clinical judgment. Your clinical assessment is the most important thing. Okay, and whenever you feel like there is a predisposition to fetal fracture, or you feel like there is a suspected fetal bleeding disorder, then you have to be very careful, because these are already relative contraindications. Okay, so now the next thing is that the table of indications. So it's very simple. The fetal, whenever you feel like there's a compromise, the CTG needs to be pathological. Okay, for example, you have to be very vigilant in such scenarios. You should know the classification of CTG for that. For example, they have told you that there are early decelerations. So early decelerations are a white feature. They are not amber or red. So the CTG with early deceleration is going to be, it's going to be reassuring, it's going to be normal. So just because the heart rate is showing deceleration doesn't mean that the CTG is pathological and you're supposed to apply an instrument. So you have to be very careful, but that you should be able to point out a pathological CTG. We'll definitely have a session on pathological CTG. And then we have the maternal features. So for example, in nulliparous, we know that we have 3 hours with a regional and 2 hours without regional if that time is already gone. And for Paris, we have 1 hour less for both maternal exhaustion or distress, or you can't apply Valsalva. So, for example, there is mitral stenosis, not maternal stenosis, or pulmonary hypertension. So, in the case of pulmonary hypertension, please remember that first of all, pregnancy is recommended. Top should be recommended if a patient with pulmonary hypertension has conceived. But if she has conceived and she wants to continue, then in that case, you're supposed to offer an elective cesarean section. Okay, but still, let's say she comes with a fully dilated to the labor room. You can't do a cesarean. It's better to deliver her vaginally, but then you should avoid the Valsalva maneuver. And for that, you're going to apply an instrument. Okay, so it's a very simple thing. Now, this is the safety. I'm sorry. Okay, this is the safety criteria for the assisted vaginal birth, and it should be very clear to all of you. This is the basis of the algorithm that we are studying. So, on abdominal and vaginal examination, preparation of mother, and preparation of staff. So there are 3 things. So for full abdominal and vaginal examination, you should know that head should be equal to or less than 1/5 palpable. What does this mean? That it should be at least at 0. When it's 1/5 palpable, it is a station 0. And then when it's less than that, it is a station +1. And when head is at 0 +1, which is the instrument we apply? I just told you. What is that called? It's called mid cavity. And what instrument do we apply? What are the names of the mid-cavity forceps? We have Keeland for rotation and Neville Barnes and Simpsons for non-rotation. So cervix should be definitely fully dilated and membrane should be absent and station should be 0 or below. That's the same as equal to 1/5 or less than 1/5 palpable. And you should be very confident of the position of the fetal head. And capit and molding should not be more than +2. This is a very important point. Molding is, if it's there, it should be reversible. Because once molding becomes +3, then it's irreversible. Okay? And the pelvis should be adequate. Very important. If you are sure then there's an element of CPD, sometimes the arches are very narrow and it's very obvious that CPD will be there, then you should not go for unnecessary trials. Okay, so then we have the preparation of mother. How are you going to prepare her? So you should definitely explain to her about the procedure, the chance of failure, what are you going to do if the instrument fails, and you should take a proper informed consent, and you should document it in the case notes. Because you don't know where is this attempt of OVD going to land, so you should have to be very careful. Then full cooperation, and she should be agreed to the whole plan. Appropriate analgesia. So guys, this is a very important question. So in mid cavity, or in let's say low cavity, you can go for regional. Regional is greater than pudendal. Okay, regional block. But if it's urgent, then you can go for pudendal block. It's for 0 and +1. But for a low or outlet, low cavity or outlet, that is +2, +3, +4, +5, you are going to go for a perineal block. So this is a very important line of the guideline, that in which forceps and at which station you're going to apply a perineal block, and when are you going to apply a pudendal block, and when are you going to apply a regional block. So please keep that in mind and try to understand it. So bladder should be emptied. So one thing I wanted to ask you, that in all the obstetric cases and procedures and in all the emergencies, we need an empty bladder. But there is one situation in which bladder should not be empty. Rather, it should be retrograde filled. And what is that scenario? Please, can anybody answer? That when the maternal bladder has to be filled. There is one, it's a very easy question, undergraduate level question, that at which obstetric emergency are you supposed to have a full bladder? Please answer the question. Okay. The answer is in cord prolapse. Okay. So it's a very easy question, very simple one. That in all the obstetric emergencies, you're supposed to empty the bladder except for cord prolapse, because in that case, the bladder should be retrograde filled. So how are you going to prepare the stuff? The operator should have the knowledge, experience, and skills necessary, and adequate facilities should be there. You should have equipment, lighting, and the most important thing is access to an OR. Because, for example, just listen to me carefully. You are applying vacuum and it fails, then you're going to apply forceps and they fail too, God forbid, then you're going to go for cesarean section. So you need the OT. So the OR should be ready. You cannot apply instrument at a place where you don't have an operating room. Please keep that in mind, okay? Always keep the chance of failure in your brain, okay? Next, we are going to talk about the backup plan, especially for mid-pelvic births. So what is the station at mid-pelvis? I just told you. Please tell me the station for mid-pelvis, and please tell me about the names of the forceps for mid-pelvis. Hurry up. Okay. The station for mid-pelvis is going to be 0 and +1. And the instruments that you're going to use for mid-pelvis are going to be, for rotation, you're going to use Keeland, or otherwise you're going to use Neville Barnes, okay, or Simpsons. So this is so in case of mid-pelvic births, it is recommended that you should apply the forceps in the operating room, because you don't know, the chance of failure is greater with a mid-pelvic station. Okay. And you should know about the complications. You should be ready. There can be a shoulder dystocia, perineal trauma, PPH, and neonatal resuscitation experts should be there. Okay, you should inform the neonatologist, because the risk of HIE is greater. There's risk of fetal trauma. So this was the safety criteria. I hope you understood it. So now we're going to go back to our... Yeah, so you can just do the whole guideline from this appendix 3. This appendix 3, this is the last page of this guideline. And it's enough for you to revise it, to review it, and to study it. You should just go back to each box, okay? So, the safety criteria for operative vaginal birth, is it met or not, okay? So I have just told you about the whole thing, what should be there. First of all, you should know about the categories and the stations. at which station which instrument you're going to apply, and at which station which block are you going to apply. So can anyone tell me that for low cavity and outlet, which block is preferred for pain relief? I just told you guys. Okay, so the perineal block is preferred for the low cavity or the outlet station, and for the mid cavity, which blocks do we have and which ones are preferred? So we have the regional block for the mid cavity. It's preferred over the pudendal block, but if it's an emergency, you can then apply a pudendal block directly. Okay. So now the safety criteria is met. You are an expert. You know how to perform it, when to perform it, and where to carry it out. Now you need to select an optimal birth place. And I've told you guys that for the mid cavity, you should do it in the OR. Otherwise, you can do it in the birth room for outlet and low cavity. Common sense. Okay. So when you're going to do it in the labor room, when head is at low pelvic or outlet. What is low pelvic? It is +2, +3. And what is outlet? It is +4, +5. No rotation or rotates easily, and no features of CPD. And you're going to give a trial in the theater. So it's very important. When you're giving a trial of operative vaginal delivery in a theater, then you should be telling the patient that if it fails, we can go for an LSCS. It's an obvious thing, okay? So when head is 1/5 palpable, which means when it is a 0, and then in head is in the mid pelvis, you need rotation. Whenever you need rotation, go to the OT, okay? Rotation, go to the OR. And features are suspicious of CPD. So students remember the station, but they forget that rotation is also a very important point, that when it's less than when rotation needed is more than 45 or equal to 45, then you should perform the operative vaginal delivery in the operating room. So how are you going to select the instrument? So very important thing that if you have forceps and you have vacuum both, and there are certain contraindications to vacuum, which include preterm 34, 32, and absolutely contraindicated at 32 and below that. So if you can use both of them in a scenario, then which one will you use? The one you are more confident with. So most competent at using. So the operator's competence matters a lot. Then to select the instrument that is least likely to fail, you should prefer to avoid sequential use of instruments. However, the algorithm says that first go for a vacuum and then go for a forceps, but sequential, because it's going to be a long process and it can cause fetal trauma and bad outcomes. First, you're going to apply vacuum, then God forbid forceps, and then a cesarean. That's a lot for the patient and for the baby as well. So avoid sequential use of instrument, okay? Make sure that you are doing it properly, okay? Then the next question is, the next point is that you should avoid vacuum assisted birth at less than 32 weeks, okay? So this is a very important point to remember, that for preterm there are two divisions for vacuum. So where is it relatively contraindicated, and where caution should be used, and where it is absolutely contraindicated. So at 30 to 36 weeks, you should do it with caution. And at less than 32 weeks, it is absolutely contraindicated. So you should remember this also, okay? So now it's very important to apply the instrument correctly, okay? So can anyone tell me about the correct application of forceps? How many chances of pulse attempts you are allowed, and when are you supposed to leave it, and when are you supposed to call a senior when you're applying a forceps? Can anyone tell me, please? It's a very important thing you should know. Meanwhile, I'm going to look for the page where it was mentioned. Just give me a second, guys. Anyone, please? Okay. Okay, so here it is mentioned. I'm just gonna read it and explain it. That so forceps, when the forceps cannot be applied easily, when the blades or handles don't approximate. So first of all, the handle should approximate, and you should be able to lock a locking forceps. But if you are unable to, lock the instrument, then in that case, what are you going to do is that you're going to discontinue. Okay, discontinue the attempt of forceps when you cannot apply it and when they are not approximated easily. And if there's a lack of progressive descent with moderate traction, then also in that case, you are going to discontinue it. Please remember this, okay? There should be a little bit of descent with moderate traction. If it's not there, then this means that there might be cephalopelvic disproportion. So CP, the element of CPD, this might be a warning for that. And then we're going to talk about the rotational forceps. Can anyone please tell me the name of the rotational forceps and at which degree do we start using a rotation forceps? Please, can anyone tell me that? Okay, so rotational forceps is the Keelan forceps, and we use it when we need a rotation of more than or equal to 45 degrees. So please remember that. Okay. Next, so if you are using a rotation forceps and you are applying it and with gentle pressure, if you are failing to achieve rotation, then stop it. You're not supposed to use a lot of force for rotation because that can be harmful. Okay. Next, if you have done 3 pulls of a correctly, the first pull you have to make sure that the instrument has been correctly applied. So let's say that you have surpassed the first 2 things. You have applied the instrument correctly, and there is approximation of the handles and it is locking, and you are able to achieve rotation also with gentle force. Then in that case, now you are allowed 3 pulls. Okay. And the sequence of 3 pulls should also be in your brain. First of all, you have done 1 pull or you have done 2 pulls. Now you have a total of 3 chances only. 3 pulls and you have failed. Then after forceps, what is the next step? Can you even tell me that you have applied the forceps according to the guideline? Let's say you have done 3 pulls and you have failed. What are you going to do then? Okay, then in that case, you are definitely going to go for a cesarean section, an elective LSCs. Okay, please remember that. Okay, so the first one of the 2 pulls is minimum descent, and this means that you have only 1 chance available. Then in that case, you should consider that have you applied it correctly, or if there is CPD, if your experience is less, and you should ask for a re-evaluation from an experienced operator because this was the last chance you had. After the 2 pulls, you have just 1 more chance because you are allowed a total of 3 pulls, right? So after the second pull, you should even after the first pull or the second pull after these, before the third pull, before going for the third pull in the same setting, you should reassess the whole scenario because you're only allowed 3 chances. After that, the patient is going to land in a cesarean section, so you actually have to assess it very carefully. Okay. So there can be morbidity associated with the failed attempt, and neonatologist should be informed. And there's increased risk. This is a very important line, guys. It's a very important question that when you are attempting a forceps birth and they are failed attempt, then there's a very high chance of fetal head impaction in that case. Okay. So very, very, very important question, potential question. Okay. So up till now, we have done the criteria for forceps. In the next session, we're going to discuss the vacuum. Thank you, guys. Thank you so much. So how are we supposed to discontinue the live? It's kind of difficult.